Hello, in this video we're going to be reviewing pretransfusion testing, a part of the blood administration procedure in IV therapy. So you just got an order to draw the type and screen in that peak-top test tube for a patient that is going for second surgery on the left lower extremity. It has been more than 72 hours since the last transfusion, and you wonder why do they want to check blood type again? A positive blood type is not going to miraculously change over the week to O negative. Well, stick around to find out why we type and screen again after more than 72 hours. First, determine patient blood type. We will be first looking at something called forward typing. Laboratory technicians take that pink top test tube of yours with patient blood sample and spin it in the centrifuge and separate red blood cells from plasma. They then put the red cells in separate test tubes, and to each test tube they will add different antibodies. In the first test tube they will add antibodies to type A cells. Let's call these antibodies anti-A antibodies. In the second test tube, they will add anti-B antibodies. And in the third test tube, they will add anti-Rh antibodies. Techs are looking for antibodies to find their antigen on the surface of red blood cells. For example, in the first test tube, if the patient has antigen A on the surface of the red blood cell, and the antibodies that they add are anti-A antibodies, antibodies will bind to those target A antigens after a period of incubation, where the antibody and antigen come together. Then techs add anti-human antibodies. Anti-human antibodies will recognize and bind to antibody A. Also, anti-human antibodies will link between each other. Cells will link together and clamp. This link can be called agglutination, or cells are agglutinated. So cells will agglutinate and be visible to the naked eye on the bottom of the test tube. So let me reiterate this. So if the patient has A antigens on the surface of the red blood cells, antibodies A will bind to them. Then adding the anti-human antibodies will bind to antibodies A and bind to each other and agglutinate on the bottom of the test tube. Thus, we will know that the blood type is A. In the similar fashion, in the third test tube, adding Rh antibodies to the test tube will give us the answer if the red blood cells have an Rh antigen on their surface. This will determine if the blood type is Rh positive or negative. So this will give us the results for someone who is A positive. Let's take a look at the next example. What do you think this is? This is B negative. Let's take a look at the next example. What do you think this is? Correct. This is AB positive. Now, let's take a look at this example. What do you think this is? Well, let's take a look at the red blood cells themselves. These particular red blood cells do not have any antigens present on their surface. So antibodies don't have anything to bind to. Agglutination in any of the test tubes. This is an example of O negative blood type, which happens to be my blood type. It makes me a great packed red blood cell donor, but not so much a great plasma donor. Reason why is because my plasma will have all the antibodies to type A red blood cells, to type B red blood cells, and red blood cells with Rh positive antigen on them. So this is an example of results of somebody who is O negative blood type in a forward typing. Forward typing is when lab techs are looking for antigens on the surface of red blood cells, patient's red blood cells, by adding known antibodies. Next way is called the reverse typing. Here, lab techs will use the patient sample again and take only plasma/serum that they separated in the centrifuge. They will add that to the test tubes. They will be looking for antibodies that already exist in the patient plasma. They will take known type of red blood cells and add them to the test tubes with patient plasma. To the first test tube, they will add type A cells. To the second test tube, they will add type B cells. And to the third test tube, they will add Rh positive cells. For the patient that has antibodies for B cells in their serum, in the second test tube, where type B cells were added, patient plasma antibodies will end up binding to those added cells. Then techs will add anti-human antibodies to the test tubes. Anti-human antibodies will bind to the anti-B antibodies, and cells will link. So there will be agglutination on the bottom of test tube where type B cells were added. In the first test tube, red blood cells will stay suspended and will not agglutinate. And if there is no Rh antibodies in the serum, then the red blood cells will stay suspended in the third test tube. In this reverse typing, second check was performed to make sure that type A positive blood is being determined. Next example, if the patient blood type is AB negative. So the patient's serum will not have A or B antibodies, but it will have the Rh antibodies. In the third test tube, antibodies will bind to Rh positive red blood cells, and after addition of anti-human antibodies, antibodies and cells will link, producing visible clumps or agglutinated cells on the bottom of the test tube. What blood type is this? This is B negative. And what blood type is this? Correct, this is O negative. Good job. So when lab technicians test the patient's serum for antibodies with known type of red blood cells to determine ABO or Rh, this is known as reverse typing. Second, lab techs will screen the blood. The human blood has three big antigens on their surface that we find first, ABO and Rh. But besides them, there could be many other small antigens on the surface. These small antigens can trigger an immune response. As the result, antibodies can be created against them. This is why patient can develop antibodies to the last blood transfusion, even though he did not have any antibodies in the past. These antibodies will be in the patient's serum. This is why we test type and screen patient blood type again after 72 hours, even though we already know what blood type patient is. Screen test is similar to reverse typing. For screen, techs want to find out if patient has any other antibodies present in their serum that can react with donor red blood cells. They take patient's serum, put it in several test tubes. Then they add donor red blood cells that they know have a rare antigen on their surface. There are about 50 different antigens that could be on the surface, all kinds of Kelly, Duffy, M and S, and so on. If the patient's serum does not have any antibodies, red blood cells stay suspended, nice and homogeneous. If the patient's serum does have antibody will agglutinate the red blood cells and clump on the bottom of the test tube. Then techs look at the whole panel and they know which antibodies patient has in the serum that will react to the donor red blood cells. This way, techs screen for antibodies. Third is cross-match. In cross-match, techs take a small sample from the unit of blood that they think is compatible with patient's blood according to the label and previous tests on the patient's blood. So the bag has a label of A positive blood type, and also in a small section a bunch of small antigens are documented that are present on red blood cells on the unit of blood. Techs take a sample from the bag, and they take a sample from the patient plasma. Then they add donor red blood cells to the patient's serum, all in the test tube. The same way it was done with the reverse typing. If the mixture does not agglutinate and stays perfectly homogeneous, conclusion is that there is no antibodies in patient plasma that will react to the donor red blood cells, that the unit of blood and patient are compatible. The unit of blood can be set aside for the patient. This unit set aside for 24 hours. In another scenario, if one test showed that the patient's serum agglutinated the donor red blood cells, then there is some antibody in patient's plasma that reacted with donor antigens. They might not know what it is because it did not show up on the screening panel or other tests. Some rare unusual antigen. The result is that the serum and the blood are incompatible. So the blood will not be issued to this patient. This is the physical mixing of donor red blood cells and serum is a manual cross-match. There's another way to do the cross-match. It is called electronic cross-match. It is more of the logical conclusion based on the previous history, documentation, typing and screening of the donor blood, and typing and screening of the patient blood. In electronic cross-match, if the results of the patient screen test all negative, so techs can say that patient does not have any antibodies in their serum, and the computer information about the unit of blood shows that there is no weird antigens on the surface of the red blood cells, then techs can trust and say unit of blood and the patient are compatible. There is no actual mixing, physical mixing of blood. In the opposite scenario, if the screen of the patient or the unit of blood showed that there is some antibodies or antigens that are reactive, then manual cross-match will be necessary. So you have just made it to the end of the video. If you found the video useful, please click that like button. I hope you enjoyed it. Thank you for watching, and I wish you great success.